2020 member event, and I want to welcome you. My name is Jan Jones-Schenk. I'm the Senior Vice President for the College of Health Professions at Western Governors University, and we're happy to have been able to offer this event as a public event this morning. And we have a special speaker who's going to talk about some of the things that all of us are experiencing and also about the future of value in the face of the current state of events. I want to just encourage you, if you'd like to tweet or use your favorite social media mode to note this event. The hashtag health value is on the screen, and I hope you'll use it. I wanted to begin this morning talking a little bit about what we're experiencing in the world today. This is a sign of our times, a time when healthcare is leading for our future on the front lines against an invisible opponent and asking others to support with what seems like kind of a dubious effort, and that effort is staying home. I think it's very hard to think of staying home as active effort against this big challenge that we're all facing. But as we have pivoted many times in preparing this event, we understand that it is equally important for us to protect our staff, our students, our members, those who are on the front line. And so I just wanted to remind all of us that staying home is part of the effort that we can do and that we must do. We began thinking that we would be broadcasting from our WGU studios. And because we are not doing that, we didn't want to assemble a group in that studio. I'm broadcasting to you today from snowy Park City, Utah, where we're in the midst of a spring blizzard. And you'll see Governor Leavitt in a few minutes broadcasting from his home as well. So we're attempting to illustrate to everyone that we can conduct business, we can do the work that we all need to do using technology, and we're really fortunate at Western Governors that we have a lot of experience in this area. I want to just take a few minutes to talk about the Accountable Care Learning Collaborative, the ACLC. It's a peer learning network. It facilitates the development of intelligence, learning, and networking for value-minded individuals and organizations. It was founded by Governor Mike Leavitt and Dr. Mark McClellan in 2015. And you can see here the website, the URL for the Accountable Care Learning Collaborative website. And I encourage you to take a look at that website. Members who are joining us today are very familiar with that. Those of you who are joining as guests, this would give you an opportunity to learn a little bit more about what this organization does. We have 2 member events a year. This was to be our spring member event in collaboration with ACHE in Chicago. These events typically include a plenary session and or panel guests, and as well as breakout committee meetings that are open to members and invited guests. And each committee has a topic for discussion around a specific value-based competency. So we'll talk a little bit more about the Atlas and some of the resources, and you can find those on the Accountable Care website. We began our actual member event yesterday with assembling a couple of committees. So you see here some of the current committees that are in operation. The Medication Optimization Committee actually met yesterday virtually. They had a great discussion, generated some really important outputs that will add value for anyone who's interested in this particular topic as it relates to value. We also have a committee on data aggregation, one on home-based care, and one on high-value partnerships. And we're tremendously grateful to InterSystems, Arcadia, CVP, 3M, and Innovacer, who are sponsors for these committees. And it is through sponsorship like this that we're able to assemble providers and have these in-depth conversations that really generate important content for everyone who's in the value journey to use. A couple of other recent committees. We had a stakeholder engagement committee that recently finished its work, a financial collaboration committee, social determinants of health integration committee, and evidence-based care committees. Again, a great sponsorship from 3M, the National Association of Community Health Centers, Medtronic, Lumeris, Merck, Accenture, the American College of Cardiology, Johnson & Johnson, Comagin, and Hanover. And this work could not have been done without the support of these sponsors who help us bring together knowledgeable experts and providers in the field and help us to facilitate those dialogues so that we can generate some committee outputs that I'll talk about right now. A couple of the outputs of the committees are the Competency Orientation Guide, which is a 2-page document that synthesizes the committee's discussions, questions, and answers, and key considerations regarding a specific value-based topic. So going back to the Medication Optimization Committee that just met for the first time yesterday, each committee meets typically 3 times. Usually one of those is face-to-face. However, that future may be slightly altered as we go forward. And so the Competency Orientation Guide is a really important output for each of those committees. There are also case study briefs, and these are 2-page documents that focus in on how a particular provider organization has been able to implement some of the recommendations and what their journey has been. So these are really great models for other organizations to be able to look at as a blueprint or a sketch, if you will, about how to implement the competency in a structured way and how a particular organization's journey has unfolded. Now, the resource that we are probably the most proud of is the Accountable Care Atlas. The Atlas is a collection of over 160 value-focused competencies. These are organizational competencies that help organizations to align their resources and their human capital around 5 different domains. These domains include governance and care delivery and HIT and finance. And each of these domains contains a set of competencies that an organization should be striving to achieve in order to be successful in value. So now I have the great pleasure to introduce our plenary session today. We have with us Governor Michael Leavitt. And for those of you who do not know, Governor Leavitt, who was Secretary of Health and Human Services, held that post during 2009 when the H1N1 epidemic was underway. So he has a unique perspective on pandemics and epidemics. He was also the EPA administrator, 3-time elected governor of Utah, and founder of Leavitt Partners. He's a co-founder of our Accountable Care Learning Collaborative, as I mentioned earlier, and author of this book, Finding Allies and Building Alliances. And for those of you who've not had the opportunity to read this book, I encourage you to do so. And if you're interested in obtaining a copy, please let us know in the Q&A or in the chat, and we'll be happy to facilitate that for you. After the governor speaks, we'll have a little time for questions and answers. And I'd like for you to please keep in mind that our moderator will be looking in the Q&A section of the WebEx to find those questions and call those out. So please enter your questions in the Q&A section and not in the chat. And now, without any further ado, I'm happy to introduce Governor Michael Leavitt.
Good morning. I'm very pleased to be with all of you. I was moved by Jan's slide of the healthcare providers who are working in very hard, difficult, and in some ways dangerous settings to serve all of us. And we are here doing our part. I suspect it's okay if we engage in just a little bit of isolation humor. This morning, I received from one of my sons a little video that maybe you've seen, maybe you haven't. I'll play it for you.
Because of coronavirus, you are going to be quarantined, but you have a choice. Do you A, quarantine with your wife and child, or B?
Well, that's clear. This is clearly authentic, and we're all enjoying this together. I want to talk today in asking this question. What will the events that we're all experiencing right now related to COVID-19 mean for the healthcare system in the United States? We're all becoming pandemic experts. We're seeing a tremendous amount of information that's coming from many sources, most of it good, not all of it, but we are, through the course of this, becoming pandemic experts. Jan mentioned that while I was Secretary of Health, I was involved in a pandemic potential virus known as the H5N1, which was an avian influenza. The thing that was most troubling to scientists was that 60% of the humans who actually got this virus died. So I received briefings as secretary, and I must say the word pandemic was new to me. The next morning after my first briefing, and after I had questioned those who were briefing me extensively, I had a visit from one of my colleagues who was much more experienced in the area of pandemics than I am or was. And he had two books in his hand. The first book was a book called The Great Influenza by John Barry, perhaps one of the most enlightening histories of the 1918 pandemic influenza. He threw the book down or tossed the book down on my desk and said, "You need to know about this. You need to understand it." He had a second book, and he tossed it on my desk. It was a green-covered congressional investigation about the 1967 swine flu, where mistakes had been made with vaccines and many people had been injured. And he said, if we don't get the first one right, the one on pandemics, there'll be one of these and you will be the center of it. Well, that got my attention, as it has, I suspect, everyone else, because these are extraordinarily important events. And over the next 3 months, I had a first-class education from the Centers for Disease Control and the National Institutes of Health and scientists from all over the world. And I became persuaded that the United States of America was not, in fact, prepared. I went to the White House. I took two books with me. The first one, I said to the president, you need to read this. Second book, I said, and if we don't, there'll be a lot of worry about why we didn't prepare. Over the course of the next few months, the Congress responded, put $7 billion on the table. And over the next 3 years, I spent as Secretary of Health moving around the country and pandemic summits and many different gatherings all over the world to try and raise the alarm, the need for us to understand. One of the things I became aware of is that pandemics are very difficult to talk about. Anything you say in advance of a pandemic is alarmist. Anything that you have done after it starts is inadequate. And we're now beginning to understand that in very personal ways. I learned that pandemics have always reshaped the political, the economic, and the cultural landscape when they occur. And this one will be no exception. I'd offer that over the course of the ensuing months, there are a number of things that we can look for. In the next few weeks, we're going to see a clash of priorities between those who are deeply concerned about the spread of this very hostile virus and those who are concerned about the impact of what's occurring with our mitigation strategies to the economy. I think we're going to see, and already are, conversations about the numbers. The numbers are not exactly easily reconciled. It's all going to boil down to a discussion of the numerator, if you will. If 200 people died and it turned out that there were 10,000 people who had the virus, that would be 2%. That would be deeply alarming. However, if it's 100,000 people, then that's 0.2%. All of us in the health world know that we lose 30,000 people or 40,000 a year, and we don't have the alarm we should. My point is that there's a lot we don't know, but what we do know is that this is a very dangerous situation we're seeing unfold in New York City as we speak. What some people believe is the US version of Wuhan. Will we be able to contain it there and stop its spread? I think most believe we will not, and that we're going to see some version of this spread throughout the United States in various degrees. My friend Tony Fauci, who is spending a lot of time on television these days, pointed out to me that virtually every generation has to learn this anew, that pandemics happen long enough apart that and he suggests that they're generation skipping, that each of us have to learn to deal with this on our own. But I might say that I think there's reason for hope and optimism, and we need to move forward. One of the things that I will acknowledge is that when you read about the pandemic of 1918, it's important to remember that the decade after was referred to as the Roaring Twenties. The economy did come back. People worked through that. It had devastating impact. We may be the generation that is best prepared to avoid that kind of a consequence because of our capacity to do exactly what we're doing, to begin to conduct and continue to do business using technology and tools, having a better understanding. And so what the message of Jan's slide of us doing our part is a very important one, and while at the same time fully appreciating the sacrifice that's being made by those who are there to care when it's needed. So with that, I would like to just shift gears and begin to talk about the future and what the pandemic virus, the COVID-19, could mean to the healthcare system. I'm reminded of an experience I had while governor. Occasionally, I'd have an opportunity to sit near the players at a basketball game of the Utah Jazz. Jerry Sloan was the coach of the Utah Jazz. He's a blue-collar coach and was a blue-collar player. And occasionally, in fact, frequently, he would stand in front of the player bench during the game, sort of stomp his feet to get their attention and shout, "Play forward, play forward." One night after the game, I said, "Coach, what do you mean when you say play forward?" He said, "When there are events that occur in a game that don't go your way, when there's a foul that's not called, or one that's called that shouldn't have been, or when there's a missed shot or a miscue, it's everyone's tendency to stop and to lament that for a few minutes, a few seconds, and to let the game move forward without you." He said it's a mistake because the good players, the great players, and he used some names, when something happens and go back to the other end of the floor and wait for the next opportunity, they play forward. That increased my understanding of what he meant, but it also taught me, I think, an important lesson about both leadership and followership, and the need for all of us to be playing forward. So with that in mind, I want to talk a bit about 5 different areas where I believe the COVID-19 will in fact affect the future of American healthcare. I'll talk a bit about the macroeconomic changes that I think it will drive. I'll talk about the healthcare policy issues that it's already evident that will begin to shift. I think it's important we think a bit about the politics of our country and how it will affect politics, because politics obviously will affect our policy and our healthcare system. The care delivery, how will care delivery be different? How will payment be different? And I think we ought to talk a bit about what it means to value. So let's start a bit about, let's start with a bit of conversation about the macroeconomic changes. We know now that at least $2 trillion will be added to the economy through various stimulus packages that are being undertaken or have now passed the Congress. That's badly needed, and I think was the right thing to do under these circumstances. But we also should remember that that will add $2 trillion to already $20 trillion of debt. I will also point out that because the economy has been dramatically downsized for at least a temporary period of time, it means that tax revenues are going to plummet during this year, and that until they recover, our spending will likely be greater. Greater expenses and a smaller amount of revenue means a greater deficit. So on top of the $2 trillion that will be created for the purpose of stimulating the economy during this very treacherous moment, we're going to see deficits that will increase. As a result, the interest rates that will be charged on that debt will be a larger percentage of the national budget than it's been in the past. Now that's critical because all of you have seen slides. I won't put one up today, but you've seen it. That shows that the percentage of our entire budget that goes for things other than interest has continued to diminish to the point that we now have less than 32% of our entire national budget that can be spent on things other than health care, that is to say, entitlements, and interest on the debt. That will increase. And over time, if interest rates were to normalize, and they will, that will become even more intense. What that means is that there's going to be substantial pressure, even more pressure than we're feeling today on the payment rates that we receive for health care. There are 2 ways that pressure could push us. It could push us into a place where value is viewed as low price, or it could push us toward a time when value, defined as we do, which is a lower price or at least a fair price for better quality. The pressure for that to occur will be very significant, and the United States will have to make a choice. Can we, in fact, make value work, or must we simply cut rates to the point that we are able to, in some way, balance our economic equation? Well, today I'll make the case that we are in a race. We're in a race to make value work. That's been one of the important missions of the ACLC, to find ways to innovate, to help us all learn, to help us to make the changes in the system that are required to make value work, as opposed to simply reducing payment rates over and over again just to be able to fit it within the nature of our budget. I'll move now to a discussion about health policy and changes in ways that health policy will be affected. There's no question that the events of coming months will reveal gaps in our healthcare system. We're going to obviously see many people who have health needs who are uninsured. There will be substantial questions about social justice and the way that plays out in American society. We're going to see many people who go into emergency rooms and into settings where their network may not apply, but they still will be required to give and receive care. We're going to see a renewed conversation about surprise billing, and there will be more evidence of the need to solve that problem. We will, in fact, begin to see a whole new range of impatience, I believe, among those who pay for care, particularly employers. I think we could begin to see a restructuring of the way benefits are delivered. Employers are likely to going to go through a period, we all are, of economic, at least, recession. And when that happens, their cost consciousness goes up dramatically. So it's clear that this will renew the pressure that's been placed by employers on the healthcare system to minimize the amount of impact it has on our economic competitiveness. So we could see things such as the reintroduction of defined contribution. That is to say, where employers pay a specific amount and employees then begin to choose the way they will have that money deployed, knowing that they will pay the difference. That will have a substantial impact on the way patients behave and the economics that providers face. We will undoubtedly begin to see a continuation of narrowed networks and those who are bearing risk looking to find ways of restricting within their network patient movement. We could even get to the point that we begin to see the use of delivery reforms like gatekeepers again. That would not be a welcome choice. In fact, all of these things are hard, and it will be driven by the economic pressure being put by the macroeconomic changes that I spoke of. Once again, pointing the way to value. We need to learn to execute on a value-based care system, or we're going to end up in a place where decisions are made that will be driving us towards simply reducing payment rates and hence by doing so, reducing quality. So let's turn then to the third component of change, and that is political. We have an election, and that election is now in the midst of its most powerful period as this pandemic begins to roll out. There have not been pandemics at any time anywhere in the world where it has not affected the structure of political power. Will the administration be seen as handling this well? Will it create a level of discontent that will simply create a momentum for change? Will the economic recovery be sufficient that it will be clear that the current leadership has done its job? I don't know the answer to any of these things, but I think we all ought to acknowledge that nothing will happen more significantly in the next 6 to 8 months to affect the politics at every level of government. That's not just national government, but the state government and members of Congress and cities. This is going to be a powerful shaping force on the way politics plays out. And I might add that in the past, when we have seen this kind of change and when there's an economic recession, government begins to play a bigger and bigger role. That's been the pattern. I think we can begin to see that may in fact be the case here. We're going to see surges in Medicare payments. We're going to see surges in Medicaid. I think it's very possible that states who are currently not expanding their Medicaid population will do so and do so quickly to assure that they have access to those healthcare dollars. So politics is going to play a big role or the pandemic is going to play a big role in the way our politics play out over the course of the next year. Let's move then to care delivery. I've mentioned already that healthcare systems are going to be under tremendous economic pressure, not only in the context of payment rates, but also the fact that through various components of our statute to care for anyone who presents themselves, and that they'll likely end up paying for a lot of care that they would normally not be providing, or they will be rendering a lot of care that they're not being paid for. I think it's also important to acknowledge that they've been through a period and will continue to go through a period where there will be cancellation of elective procedures. That has changed the economics, not just of hospitals, but anyone who sells to a hospital. This has a cascading effect on the entire healthcare sector. Let's move for a moment to payment. I've mentioned already that we'll likely see more Medicaid. We'll likely continue to see more influence with Medicare. And this raises the question that I mentioned a few moments ago, the issues related to value. Large employers could begin to view a moment like this as that value is just lower price. If that occurs, much of the progress of the past couple of years could in fact be diminished. So we're in a race here. And that's the reason that the ACLC is so important, and so your attendance here is so important. It's very clear that Medicare and Medicaid, because of the macroeconomic components that I talked about, in addition to employers, may in fact begin to demand more for fewer dollars. Again, we're in a bit of a race here. And I think it's also evident that the pressure that employers are feeling from the shift of dollars going from them to subsidize Medicare and Medicaid will become more intense. Well, I'd like to just conclude for a moment before we go to questions. I'd like to just talk a bit about the ACLC. It was mentioned that Dr. Mark McClellan and I were the conveners originally of this. We knew that value was the future. We also knew that we weren't yet prepared for it, that it was going to take time, that there was no book to read on this. We were inventing, pioneering, innovating as a country, all trying to figure this out. Well, the truth is we've made a fair amount of progress, but the reality is we have much more still to make. And now we have this tremendous new pressure economically. So ACLC is actually about identifying, recording, and then educating people on the competencies that are required. Jan mentioned that's what we spent a lot of time being able to create and document these. And you're here because you may, in fact, have become interested in those. But here's the point I'd like to conclude and then go to questions and discussion. We need you. This is essentially, I think, the way in which we all can come together and work together. In the last 3 years, we've had work groups of a few hundred people. We need thousands of people. We need you. We need your organization. We need the capacity to find ways of spreading the learning. And this is a learning network among, as Jan suggested, among individuals and organizations who are value-oriented. There are other organizations that are doing similar things. Our role is to find what they are learning and to include it. You've had a chance to preview the Atlas. This is basically a roadmap, a pathway for organizations of various types. That's just one of the products. So I hope that you will, in fact, be stimulated by what you hear today, become involved. I think if you put your name in the comments and said you'd be willing to be on a work group or to do something to begin to accelerate this, that there would be a joy at ACLC. So we would ask that you please do that. I'd like to just put a shout out to Western Governors University. Western Governors University has the largest health school in America. I think nearly 30,000 students of their 120,000 students. Their unique capacity is to advance students on the basis of, at their own pace, using technology, and by measuring their competency. Competency, that's what we're all about, is identifying in the ACLC, identifying competency, documenting competency, and spreading competency. And Western Governors University has been a great home for this, and we're deeply appreciative of the commitment that they have made. So I'd like to pause now, and with the faith that the people who are running this operation will figure out a way for me to be able to hear from all of you. And Jan, I suspect that you are or Daniel, someone is going to help us figure this out.
This is Daniel. I do have a question from Rhonda Toller. The question is, how do you see two-sided risk evolving in the new environment? Do you think the federal agency will retrench on their push to two-sided risk alternative payment models?
Well, I think this is a very good question because it illustrates this race we're in. HHS had said they were going to push forward and push faster. So you could see one of two things happening. You could see them saying, we're going to be under a lot of pressure, so we're not going to do that. Or you could say, we need this more than ever. And I think the current administration will say, we need this more than ever. We've just added maybe as much as $4 trillion to the deficit. We're going to have enormous pressure. We have to find ways to do this that will not, in fact, cause a diminishment of our quality. So, Rhonda, my thought is that we'll see it accelerate, not diminish in speed.
Next question is from David Strickland, and he asks, how would you advise small and rural hospital CEOs specifically to be thinking about the near future?
Well, I think all of us, every CEO in a small, particularly rural hospital, will be thinking, first of all, how can they serve their patients in their area. One of the things we also know is that there is in many smaller hospitals, there's a lack of facilities for acute care, and they're likely to see some. They may not have enough ventilators like everyone else. And so the first thing I'm sure most of them are thinking about is how can we get through the next 6 months and serve the people who depend on us. And I think that would be, I'd recommend, first of all, that they work with their state public health officials who are managing the pandemic response, and they're with their hospital association to form alliances so that they can, in fact, do that. Beyond that, may I say, I think there's always going to be a place for the rural hospital. I do think we're going to begin to see rural hospitals needing to dramatically change in their cost structure. And that will mean, in my view, adopting technology that will link them into larger health settings where they can basically use technology for the purpose of being able to become care nodes on larger systems. That doesn't mean that hospitals have to merge, but it does mean they've got to get their cost structure down by 30 or 40% in order to remain competitive. And that will be particularly true if as we see the cost structure coming under even more pressure. So those would be my suggestions, that first, focus on cost structure. Second of all, finding new ways to achieve that by essentially looking to align, not necessarily in ownership, though many will do that, but align with a number of organizations who've begun to provide access to very sophisticated advanced treatment through technology using their facility as a treatment point, but linked to more sophisticated centers.
The next question is from Anna Maria Jolly. She asks if you can talk about the implications of the federal government possibly wanting people to go back to work for purposes of improving the economy, while state leadership might be opposed to that because of the pandemic and the need to stay home.
Well, first, I'd like to talk a bit about the role that everyone plays in a pandemic situation. There is a role for everyone. There is a role for the federal government. The federal government makes most of the progress on vaccines, and they uniquely can do that. The federal government has to be in the position to make approvals on antivirals as they begin to get into the market and other medical solutions. Federal government can do what it has done in the last few days, and that's add a lot of money to state and local public health and to healthcare, the providing of healthcare. The federal government's good at collecting money and distributing it. The federal government can also gather information and provide the learnings that are happening in one area to another. Those are unique roles of the. But as a person who's been through a couple of pretty sizable emergencies as a federal officer, it became very evident to me that federal government does not have the capacity to put people on the ground in most emergencies. For example, you take Katrina, for example, or a large regional weather event. The federal government responded by calling the states and saying, could you send your emergency management people to respond to this emergency? And they did. In a pandemic, that won't be possible because everyone will be there dealing with their own circumstance. It is the most local of emergencies because it's happening everywhere at once. And so we do see, because the media now is increasingly national, we see the White House and Dr. Fauci and CDC playing what appear to be outsized roles in the way this is managed. But the reality is, this is not managed out of Washington. It's going to be managed in each state and in each local community. And in each of those states and local communities, there are going to be different situations. New York City is an intense place right now. The forecast is that their facilities will be overrun in the next 2 weeks. And so the country is working to try and supplement what they're doing there. But it isn't like that everywhere right now. And therefore, even in New York, Governor Cuomo was saying there are parts of New York that need not respond the way we are in New York City. And they're trying to sort of draw a circle around it and contain it there. Well, I think we're going to see the pressure you've spoken of play out in that way. Now, I think no one is arguing kind of containment that we're doing, the mitigation that we're doing right now is very important, and everyone is being encouraged to do it. The question is going to happen in 3 weeks, in my judgment. That's when the president said, I'd like to see by Easter, everyone feeling good about going back to work. Well, we all would. And Dr. Fauci has said that's a very flexible point. And I think what the president's doing is trying to keep everyone optimistic and looking forward and knowing that there's an end to this. I personally believe when we get to that point, we're going to have a little more experience than we do today. We're going to have been through New York and watching what they're doing and knowing that that's probably going to happen in a bunch of other cities. And we're going to be very careful about the way we begin to return to work. But there will be a point when we do. And I don't think we can forecast exactly when that is, but I think it will likely happen, not on a national basis, but on a state by state, area by area, as the science and the public policy makers judge it to be. Now, I had a conversation yesterday with a reporter saying, isn't that a terrible system because you could have some people go back to work and they could be spreading the virus. We don't know yet exactly how that's going to play out. What we know is, I think we're going to learn is week to week, we have to manage this according to what we've learned in the previous days and weeks.
Governor, you mentioned that the demand on the healthcare system, and a follow-up question is, do you see outpatient hospital settings like orthopedics and others that are not traditionally providing this type of care being utilized for any potential overflow for COVID patients?
I do. And I think that's the reason that we're seeing a dramatic reduction in elective surgeries. And in most cases, they're just not doing them. And we've all known some patient who's been turned away for care or some previously scheduled procedure not done because of that. And I think when we get into the intense periods of this, that it will be all hands on deck and every part of facilities will be used for this, and that if you read the history of what's happened in previous pandemics, and if you watch closely what's happened in places around the world where this spiked, like Italy and Wuhan, we're going to have some of those moments. I just don't think there's any question about it. And I lament it. I wish it weren't true, but I think we will. And when that happens, it won't happen everywhere that way, but when it does, yes, I think we'll see other sections of hospitals turned for that purpose.
Thank you. That question was from Megan Wright. Thanks, Megan, for the question. Next question from Craig Hiddle. Is the federal government going to tie relief package funding for hospitals to value and outcome metrics?
I don't think the legislation will, but I feel some confidence that those will remain a priority at HHS. Now, they're probably not going to not pay someone for care that they've rendered in the heart of this emergency because they didn't comport with the value aspirations that they have. But I don't think that means that going forward that we won't have national objectives and incentives to perform that way.
The next question is from Eric Weaver. What do you think will be the impact on mental health in our society, and how our industry will respond to emerging challenges in managing mental health issues in our patient populations?
So I think it's evident that mental health issues in a time like this are going to be quite dramatically exacerbated. And I think for a short period of time while we're getting through the crisis, we'll probably not be paying the attention to it that we should. But it's going to be evident as we get further along that it is an acute part of this experience. I hadn't mentioned, or I had intended to mention and didn't, one of the major policy changes that's occurred is telemedicine. For years, we have struggled with a series of issues related to the practice of medicine and the use of technology in doing so across state boundaries, et cetera. Those have been lifted. One of the areas that I think we'll see it deployed most rapidly will be in the area of mental, the ability to provide care using technology like we are today to work with patients.
Thank you, Governor. The next question from Linda Gunn. How do you see the role of local health departments changing due to the pandemic?
Public health has been a stepchild in the healthcare system for a long time. And two things have occurred that have, I think, suddenly caused everyone to realize we need those skills at the table. One is value and the whole area of social determinants of health, and acknowledgement that you can't make value work unless you're able to get a bit upstream. And the second will be events like we're experiencing right now with the COVID-19. Public health has a undeniable knowledge of these things that it is of undeniable value. And I think public health will become both better appreciated and more vibrantly used. We need their skills. I've spent a lot of my time the last several years trying to be a bridge between public health and the healthcare providers, particularly hospitals. It's surprising to me when I go into a community to bring to convene for some purpose and bring public health and private public health and the balance of the healthcare system together, that they don't always know each other. I might add the same is true with community health centers. Community health centers are somewhere in between the public health setting and people don't know them because they have not been part of the mainstream, and they need to be. They need to not be just seen as safety nets or as policy people. They need to be seen as foundation pieces of the entire system.
Governor, next question is from Joel James. Do you think this will have a lasting effect on the practice of private medicine? Many independent groups depend on elective procedures and surgeries. An extended shutdown could force many out of business and put patients into hospitals.
As I've said earlier, I do think that this is a seminal moment in American healthcare history, and it will force changes or produce changes that are still hard to predict. But one that seems evident to me is that if you go through that, there will be businesses in all sectors, including healthcare, that will be affected. Now, we'll get through it and it will adjust, but there's going to be economic damage here, and there's going to be a change in the way things happen as a result of this. This is not someone's fault. This is biologic fact. It's just part of human history. And we've had 3 pandemics in the last 100 years. We've had 10 in the last 300 years. Pandemics happen and they are reshaping events. And we're going to see a lot of reshaping. Specifically, do I think it will affect it? Yes, clearly the changes in elective procedures are going to have, it's just arithmetic. It's having an effect on the businesses that I'm involved in. And I'm spending a good share of my time right now trying to figure out how we're going to react to it. I know we'll get through it. I know that we'll, as a country, come out on the other end and that they'll find economic prosperity again. But this is not going to be an easy time for us. But we're up to it.
Governor, next question is from a researcher. What do you feel the impact would be on the value movement if CMS were to delay the rollout of their boldest alternative payment models like direct contracting or even potentially primary care first?
We saw at the beginning of this administration when Secretary Price delayed or made involuntary a few of the changes. He viewed these quite a bit differently than Alex Azar does, and I think the administration as a whole now. I think if they delayed them, it would be hurtful. And I think the impact of that, if they did delay them, is that we would see no less price pressure. We would see just fewer alternatives. We would see the charge master used as a means as a clamp to begin to clamp down on payment, and we become a much more command and control, centrally organized system that would be that I think would ultimately not provide the kind of value or the kind of services and the kind of practice atmosphere that people would choose to live in.
Governor and audience, I'll just let everybody know I think this will be the last question, and then we'll invite Jan back. Question from Joe Pfeiffer. Hearing about the staggering impacts the pandemic will have on hospital finances as CFOs are modeling, there's currently a distrust to an extent of hospitals, and so afraid that their message of these costs will be discounted. Any advice on that?
Joe, I think in certain hospitals, for example, in New York, where we're going to see people in a situation where a lot of things that a lot of systems we have traditionally relied on break down. I think we're going to end up throwing the book out for a while and just doing the best we can. When that happens, there are a couple of alternatives. One is that you can, or at least one of the things that can happen is that it's an opportunity and a moment for change. For those who don't know, Joe is the heads the health finance, the HMFA or HFMA, sorry, is the chief financial officers of hospital systems and has been a leader in being able to push for change in the way the healthcare system is organized and the way charges are made. And I think this may present a great opportunity for the things that you are doing as an association to try and make payment more logical and to create a more predictable pathway for hospitals. So this may increase the opportunity for change and the things that I know you are advocating. I would like to just end with one other thing, Daniel, before we go back to Jan. I noticed yesterday that the Tokyo Olympics were rescheduled for shortly after the beginning of 2021. We're still going to call them the 2020 Olympics. But many of you know that in the state where I was governor, we had the Olympics in 2002. And I've often told the story, and I'd like to tell it again, of the lighting of the Olympic flame. We were in Olympia, Greece. And the torch that lights the Olympic flame was lighted on the grounds of the original Olympics. It was a very small and quite solemn occasion, and a group of Olympic figures dressed as Olympic goddesses came out in front of the Gothic columns that were there in the place where the games were held. And there was a small bowl that sat on the ground that was concave and metal. And the person who was standing in front put some flammable material in that bowl. And the sun heated the bowl, and within a second or two, there was smoke, and then a flame lighted. And there was a woman holding the torch, and she put the torch down into the bowl, and it lighted. And it was at that moment I realized the Olympic torch flame is actually the sun. But she stood there for a moment, and out of the woods that were adjacent came another runner, a person dressed in an Olympic uniform that was the current Olympic uniform, holding a torch that was the torch of the Olympic Games, in that case, the 2002 Winter Olympic Games in Salt Lake City. And the torch runner held the torch up and then began to run. And it became part of the Olympic torch relay, went all over the world and went through the United States. And everywhere it would go, there would be people who would turn out at the side of the road to see this Olympic flame go by. And I remember one day saying to the woman that was organizing it, why is it that people just turn up to see fire on a stick? I'm kind of surprised. She said, well, it's clear you don't understand what this is. She said, I'll tell you a story about something that reinforces it. She said, last week we had a gap in our runners, and we went to a school, and my assistant said to the school secretary, I need a runner. Give me somebody that needs a lift. I don't want the student body president. I don't want the principal. Give me somebody that needs a lift. And the school secretary said, I know just the little boy. And within a few minutes, they were dressing up a little undersized fifth grader in the the uniform of the Olympic Games. And they led him to the street, and the torch approached, and they lighted a new torch, and he began to run down the street, and there were people on both sides cheering for him. And he got to the school, and on the front lawn of the school, there were hundreds of school kids, his classmates, who were there to watch the Olympic flame go by. And he did something that was totally unauthorized. He just stopped and turned to the students on the lawn of the school, held it up, and they just cheered. And the school secretary wrote to me, the woman who organized it, and said, "Thank you for coming. It was such a great thing." And then she said, referring to this little undersized fifth grader, "He doesn't sit alone anymore." She said, that is why this has so much power. It's because it's not about a bunch of sports. It's about our aspiration as people to be better and to overcome hardship and to be the best people we can be. That's what the fire on the stick is. I tell that story in concluding today because we're going through a very tough time as a country. And we need to remember that the fire on the stick, what keeps America, makes America not just a great nation, but the greatest nation that has possessed the earth, is our sense of compassion and love for one another as people, and our ability to innovate and to be resilient and to overcome. And every generation has had something they've had to go through. There have been wars, there have been depressions, there have been pandemics. And in each case, they came through and earned another generation's worthiness to be said we're a great nation. I have every confidence and optimism that yes, we have challenges. We're going to get through this. And the fact that we're here today and that we're moving forward, we're playing forward, tells me that that fire on the stick is still very much alive. Jan, thanks for allowing me to be part of today.
Thank you so much, Governor. Your words were formative, important, and inspirational. I myself feel I needed a little lift this morning. So I appreciate the lift from the fire on the stick. And I think those are words that can sustain us as we go forward today and into this challenging future with optimism and hope for new days to come. So thank you so much.
My pleasure.
For those of you who have stayed with us, we want to take a few minutes, a few more minutes of your time, and ask that you indulge us in collecting some information about how the Accountable Care Learning Collaborative and our efforts here in Health Value can continue to support you, to be of value to you. So we're going to start with a few polling questions. The first one is kind of a fun one, really about your social media platform. And I'll just remind you that if you are using social media today, or if you plan to use it later on in the day, please consider using our hashtag health value. So you'll see over in the corner of your screen the current poll. And we'd like you to please enter your answer. What is your preferred social media platform? Go ahead and click the button by your preferred platform, hit the submit, and in a few minutes we'll look at a relaxing slide here as we gather this information. And you'll see the results of the poll in just a few minutes. This is a deep breath moment. And do we have results? Like we have a few more minutes here to collect results. While we're waiting for that data to come up, I want to just say a couple of more words about committees. So this morning when I talked about the committee work and how important this work has been, I failed to mention two important sponsors for the Medication Optimization Committee. I want to acknowledge now the National Pharmaceutical Council and the Managed Care Association for their sponsorship and support of the Medication Optimization Committee. And now we're seeing the results here. You should be able to see on your screen the results for social media. It looks like LinkedIn at 27%, Twitter at 9%. So what we know now is the poll works. Now we're going to ask some real questions. So this next question is about our committees, our upcoming committees. We have committees that we're working on for social determinants of health integration, which is a part 2 of a bit of work we've already begun, a committee on workforce alignment, a committee on behavioral health integration, a rural health value strategy committee, and then we're also discussing the need to update the atlas that I mentioned earlier today, the atlas which contains the 160 competencies, organizational competencies for value. So these are works that we are contemplating in the coming months, and we'd like you now to please indicate your interest. Please indicate all of your interests in regard to which of these committees or efforts you would like to participate in, or minimally like to see us proceed with as we try and determine where to put most of our focus. And for this polling period, we're going to have a visual rest from the Texas bluebonnets, one of my favorite flowers, and no matter what's happening in the world, we can always count on the Texas bluebonnets in the spring. I don't know if they're blooming now. Perhaps somebody in Texas has that insight. But a beautiful photo to provide a moment of reflection as we gather your answers on this question. Please mark your answer and hit the submit button. Looks like the answers are coming in. Appreciate you staying with us through these last few minutes as we collect information about how to better serve you. And as those answers finish coming in, I'm going to go to the next slide. We begin thinking about your next answer. So one thing that we've thought about is providing some additional presentations like the one today. Maybe we do provide regularly some webinars on specific committee topics and other topics, policy briefs, and other sorts of informational opportunities. We'd like to know if this format and something similar to this is something that you would be interested in, content-specific presentations like this. But in addition to that, we wanted to pose the notion of coupling that content-specific presentation with perhaps a listening post or a format or a forum for you to tell us what you're experiencing in the field and be able to do some similar Q&As like we've done this morning and begin to collect greater knowledge and intelligence about what are the troubling challenges in the field. So if you are interested in additional presentations like this that are focused on specific content areas, current issues, and provide Q&A, as well as a listening post, please answer this next question. Now we're just seeing the data on the last question.
Jan,
Yes,
can I interject really quick?
of course.
Realize we didn't have an other option on the last question, so if there are other committee topics that audience members are interested in, we'd love for you to post that in the Q&A if there's a
Great
specific
point.
committee you want.
That's a great point, Daniel. So please do, if you have additional topic ideas that you think are critical, that you'd like us to consider, please post those in the Q&A. Really strong results for the social determinants of health integration. Obviously, a big need, the behavioral health area, a big need. Thank you for your answers. And you will now be seeing the poll for this question, question number 2, additional presentations. And that poll should
And
be,
I think let's move to the next one. I think we need to come back to this one.
okay. We will come back. Oh, here's our moment of meditation. And the next one is ACLC case study brief. So I mentioned to you before the ACLC case study briefs that are available, that are developed by organizations who have focused on a particular competency, and they're telling their journey story about that competency and how they've implemented it in their organization. So our question here, and some of you may not have enough experience with the case study briefs to fully answer this, so answer it to your best ability. In which ways are you most likely to use these case study briefs to accelerate value in your organization? The options are for personal development, team training, leadership strategy, board education, and then, of course, you may have other ideas about how a resource like this could accelerate or add value to your own journey within your organization. Please feel free to give us your thoughts if your answer is other, and we'll take just a couple of minutes to collect your responses. I'm going to go ahead and click my response right now and hit submit. And as we collect those responses, our deep breath moment. Those data are coming in now. We'll display those in just a minute. For those of you who have already answered, we'll go on and talk about the next polling question. This is about the ACLC competency orientation guides. So these are really the sort of foundational documents of the findings, the synthesis of findings that come from the committee work. There's learnings and key insights, as well as guidance for how to move forward on a particular topic. The example here is the Committee on Risk Stratification. And you can see a little bit about the format of those. We're now seeing the data come in from the last question, and looks like leadership development is the the big winner there in terms of how the case study briefs might be of value. The question here for question number 4 is very similar. In which ways are you likely to use the ACLC competency orientation guides to accelerate value in your organization? The same options are offered here: personal development, team training, leadership strategy, board education, and other. So please take a moment and enter your response in the poll. And hit submit. Those data are coming in now. We'll have those responses in just a minute. I'm going to move now to the ACLC white papers. White papers are also a product that can be generated out of committee work on a specific topic. You see 2 of our most recent white papers here, both of which I think are really excellent reads, and I would highly recommend those of you who are interested in these, who are not familiar with them, please go to our website, the ACLC website, and I'll make that information available again at the end. And download these. So one is the skills and mindsets of leadership teams in successful ACOs, and the other is the vision for a coordinated care network. In this particular question, we'd like to know in which ways are you most likely to use ACLC white papers to accelerate value in your organization. So the same responses as the prior 2 questions: personal development, team training, leadership strategy, board education, or other. And just a couple more comments about the white papers. The leadership team's white paper, which is the one titled Skills and Mindsets of Leadership Teams, introduces a series of tools designed to aid ACO leaders in assessing and enhancing their leadership team skills. The Coordinated Care Network white paper presents the core competencies a system of care must attain to successfully achieve seamless and integrated care throughout what is traditionally designed as the post-acute care space. So it proposes a new mental model regarding this sector called a coordinated care network. This white paper also introduces a series of tools designed to aid a system of care in developing their own coordinated care network. So please indicate, if you will, on the poll which of these particular areas, or if you have one that we have not listed here, feel free to choose other. Moment of reflection as we collect that data. And we're nearly done. I want to thank you for hanging in here with us. I'm going to take us to the next question as we collect the data on the white papers. So as I had mentioned a couple of times before, the Accountable Care Atlas is a collection of 160 value-focused competencies that really focus on what an organization must achieve competency in order to be successful in implementing, fully implementing, and succeeding in value-based care. So we believe this atlas is really the roadmap. It's the navigational tool that can help organizations through a transition that isn't always obvious and often isn't easy. But the atlas is a tool that can help teams understand the competencies that must be achieved. Asking again the same question, in which ways are you most likely to use the Accountable Care Atlas to accelerate value in your organization? And the options are personal development, team training, leadership strategy, board education. Feel free, of course, to enter other if you have other methods. And our reflection, isn't this a beautiful reflection photo? Fields of lavender. One thing remote doesn't let us do is transmit scent. And the data is coming in on this last question. Daniel, will we be going back to the other question?
Yes, Jen, we can go back. We've got an extra question regarding the Atlas that's to do with next steps.
Oh, that's
Consider
right.
the revision, and then we can go back to that question that we skipped.
Yeah, so as this data on question 6, the Accountable Care Atlas is coming in, we do have a second question, and that is, in which ways would you most likely participate in a value-based competency atlas revision? So as I mentioned previously, we've had quite a bit of dialogue recently about whether or not a revision of the atlas would help organizations who have a specific provider type focus, who are functioning in a specific kind of community or area or region. So this question has to do with, in which ways would you likely participate in a value-based competency atlas revision? And the responses, you can select as many as you'd like. Participate on an advisory board that guides work groups. Participate on a work group that is focused on a specific provider type. ADN, provider group, rural health. Promote within your organization. Contribute to external promotion efforts, so getting the word out through social media, conferences, etc., about the value of the Atlas and how it can be used. And of course, any other ways in which you feel an Atlas revision could be developed and promoted. While those data are coming in, I do want to return to the question about additional presentations. And we'd really like your feedback on this, whether your needs are content, networking, current issues, Q&A, listening post. What are the needs that you think presentations like this or opportunities like this, remote opportunities, could afford in assisting you all as you're navigating the current pandemic, as well as other changes that you may be encountering that we can help to assist you with. So I believe the Atlas, final Atlas question responses are coming in now. And we'll go to this question in just a minute. And while we wait for that, back to the Bluebonnets. We should be seeing those last results in just a second. And there are the Atlas results. Thank you. And here is the last question. How frequently would you be interested in joining additional content-specific presentation with Q&A that address current issues? Choose multiple or one option. Please make your choice now. And submit. Now we're coming up on the top of the hour. I don't want to hold people any longer. I hope that you will answer all the polling questions. It's very important to us to hear from you and to know what you're experiencing as you're going through this very difficult time. We as a nation and as leaders in healthcare are deeply focused right now on the events at hand. We're triaging, if you will. And we're marshaling all of our resources to care for our communities and to attack this silent opponent smartly and effectively as we can. But we also need to lift our gaze to the future. What we're learning about the aspects of our systems and those aspects that have not been sufficient to prepare us for the tests we're facing now must help us frame this new future. We believe the path to value is the future of newer and better healthcare. And we'd like to thank you for spending some time with us this morning. Our special thanks to Governor Leavitt for his inspirational and informative remarks. We do have the event plenary recording available at this website. It is the Accountable Care Learning Collaborative, so accountablecarelc.org. You can go to the website to find the recording there. I see that our final polling question has been answered and is up on the screen. And with that, I would just ask you one more time to use the hashtag #HealthValue. And I hope your day and your week ahead is safe for you and your families. And we look forward to continued collaboration with you and the Accountable Care Learning Collaborative and many of the guests and members that have joined us today. So goodbye for now. Thank you all.